Good morning, everybody. I know since you're all type A personalities, you're watching the clock. Both of them are wrong. So my advice is to guess which one is the right one and then follow it. How about that? So these are my disclosures, which are not relevant to this talk. And we're here to celebrate the inaugural Linda Repa-Eschen lecture. So let me tell you about Linda, who was a business manager in the Department of Medicine for years. She started her career as an English teacher at these two high schools in St. Louis. Then she came to WashU, and she blessed us with her presence for 40 years. First at Jewish Hospital, and then in the Department of Medicine. So at Jewish Hospital with Lou Avioli, she founded a nonprofit to address challenges in healthcare called the Lifestyle and Health Corporation. So after Lou died, she guided that nonprofit for 20 years, doing great good. And at the time of her passing, she designated that the funds of that would go to the Department of Medicine to support lectures that would focus on medical conditions that generally were associated with discrimination, complex ethical issues. So she did much more than that. For years in the endocrine division, she coordinated staggering growth in research, teaching, and clinical operations. And she was absolutely committed to excellence, mentorship, and integrity. She was particularly important of the people that she mentored who have become leaders in administration at WashU. And that includes Rachel Smith, who was hired by Linda, Sherry Bennis-Muth, Sherry Ellis, all are directors in different areas, the business office, the FPP, and the endocrinology. And she was intensely proud of the division administrators. This is a group that she always said, if you want to decrease suffering in the world, you first have to implement policies. And so the administrators got stuff done. She used a different word than stuff. These are the current administrators. I hope I didn't leave anybody out. But we should be intensely proud of them because they do great good every single day, and we appreciate them, exactly like what Linda did. So Linda's family is here, John Eschen and her daughter, Jessica, and several critical members of her family and friends. And so special recognition to Tom Eschen and Dex Schreier, who actually were members of this board that integrated the transfer of funds from the nonprofit to Washington University. So I'd like to ask all of them to stand up, please, so you can see how many family and friends. If you can stand up, I know we've all reached a certain age, but it hurts. Thank you. All right, this is me. I work at Washington University. And the title of my talk is a little bit atypical. It's called Diabetes, Obesity, and the Quest for Certainty. And to give away the end, this is something that's been thought about by physicians and scientists for millennia. And the quest is futile, but I'm going to explain why, and why what you do is so incredibly important to decrease human suffering every single day. So I'm going to begin with a case, and to be honest, it's a disturbing case, because it resonated with me, and I still think about this interaction. So this is an 80-year-old woman with obesity and type 2 diabetes who I took care of for about 20 years. She had diabetes for 30 years, and because they always have fellows follow me around to make sure I don't screw up, she had outstanding control. So excellent glycemic control, but chronically elevated triglycerides. She had decades of RAS inhibition. She took statins. She took fibrates even before it was sexy. She had stable CKD. It was non-progressive, didn't have much microalbuminuria, and had mild retinopathy. And she was the power broker in her family. She was active on the farm. She managed the finances. She was really smart and dynamic. So these are her labs to prove what I just said. Great A1C, blood pressure goals all the time. She measured it at home. LDL at goal, mild hypertriglyceridemia. She was on an SGLT2 inhibitor, a GLP-1 agonist, metformin, and a long-acting insulin. So she was exposed to SARS-CoV-2 by a COVID-skeptical son who came back at a dinner and was ill, but said, this is no big deal, we shouldn't be wearing masks. And so this disturbed her, and she knew something was wrong when this happened. So this was a person who actually followed all the recommendations for months and was incredibly rigorous about doing things. She was a responsible person. So that happened on a Thursday. She called me on Friday because she didn't feel well. Saturday, she went to the ER because she was short of breath and hypoxemic. Sunday, she was on a vent, and Monday, she had died. So her lungs basically melted. So while we were getting her transferred for ECMO, she passed. strangely, the other really difficult part about this that still bothers me, she died about a week and a half before the first vaccine was available. The vaccines were available here in early December, so this happened in late November of 2020. It was a very disturbing thing, and somebody I was close to. I lost 3 patients in a similar manner about this about the same time. It was just very disturbing. So, strangely enough, her husband, who is a very nice person, and I still continue to see, he has coronary disease, angina, doesn't take care of his diabetes. All he had from all of this was a bad cold. His cold was bad. So just the vagaries of human nature. So her husband came to me soon after this happened and said something that caused a rift in the force for me, because he mentioned 2 words that were very disturbing to me and made me think, and then I still think a lot about this. This was an incredibly tense time because they'd been married forever. They were partners in life and did good things in the world. And he's just lost his life partner, and he wanted to know the answer to this question. He screamed at me, "Doc," he always calls me Doc. "Tell me the truth," and he emphasized truth. "Are you certain," he emphasized certain, "that we did everything possible for my wife?" So this actually resonated with me and upset me, and I thought about this a lot, and I still think about this a lot. So these pursuits of truth and certainty, these are terms we banter around all the time, especially on social media, certainly define the human condition, this pursuit. The pursuits drove the Age of Enlightenment, which were also associated with the pandemic. I'll talk a little bit about that later. Immanuel Kant was the person who actually first coined this term, Age of Enlightenment. This was catalyzed by a global pandemic and an amazing period of advances in technology. This included Galileo and telescopes, Leeuwenhoek and microscopes, and it led to an explosion in thought about the nature of reality, truth, and certainty, something that we all like to think that we know something about. So the person that perhaps best characterized this was a young genius named Blaise Pascal. So Pascal, if you do the math here, he died at the age of 39 of uncertain causes, probably some god-awful malignancy. But he had chops in almost every discipline of modern science and medicine. He was the first person to figure out formulas for fluid mechanics. So he determined how fluids work in a tube, and you can measure blood pressure in kilopascals. The engineers use kilopascals as measurements. We use millimeters of mercury. He was the first person credited with developing probability theory. This is still some of his ideas are in use today. He invented a mechanical calculator in 1642 that was used pretty much the same way until the 1940s. He's credited with the invention of the roulette wheel. That's kind of interesting because he developed probability theory. This is probably still his invention. And because he said, there's so much uncertainty in the world, he developed something called Pascal's wager, which was his probabilistic argument for the existence of God, which is still talked about philosophers and theologians today. So he's famous for saying, we desire truth and find within ourselves only uncertainty. So I'm going to start off by adding a substantial amount of information about the fact that diabetes is not really what you think it is. So many of you think it's a disorder of glucose metabolism. It's much more than that. So there's a person named Oskar Minkowski. Does anybody know Oskar Minkowski? A famous physiologist. So Minkowski was revitalized in terms of his fame by the late Dennis McGarry, who was somebody I knew well, who was at Texas Southwestern, in a paper in Science in 1992. And the title of the article was the provocative, what if Minkowski had been a Jusic? Does anybody know what a Jusia is? Inability to taste. So Minkowski, who was kind of a pompous guy and very famous, like, perhaps a lot of professors at Washington University. I can't believe I said that, so. So Minkowski was doing to dogs what we do with mice now. In mice we use Cres, we do tissue-specific inactivation, we physiologically characterize the mice. In dogs, he was cutting out organs and see what happened. So he cut out the pancreas and noticed that the dogs started urinating a whole lot because of an osmotic diuresis. And this may be an apocryphal story, but it's said all through Google. You can find it everywhere. He saw all this urine, and with a large audience around him, there were lots of residents and fellows and students there. He walked over to the urine, took his hand, wiped it through the urine, and tasted it. And he said, it's sweet. So diabetes is a disorder of glucose metabolism. So Dennis McGarry said, oh my gosh, if we had just had Minkowski and been able to taste anything, we would have realized that it's so much more than that. It's a disorder of protein metabolism, of micronutrients, of behavior, and importantly of lipid metabolism as well. So you guys may or may not know that fatty acids and triglycerides are elevated long before glucose in people with insulin resistance. Fatty acids and triglycerides are enriched in these lipids in type 1 and type 2 diabetes. There are very similar differences between these in terms of phenotyping. And there are discrete lipids that increase diabetes risk, and there are some that decrease diabetes risk. Ceramides are popular now. Ceramides may cause diabetes, we'll see. And there is something called FAFAs, which are branched-chain fatty acids that I won't go into the details are, that may decrease diabetes risk. So just to throw a little bit of my science in, for the last 20 or 30 years, we studied this beautiful protein that's been crystallized. And the take-home lesson of this is you can actually get very fat and have very disrupted lipid physiology, not by eating fat, by eating too much glucose. So if you eat too much glucose, you can make a whole lot of fat. And this is the protein that does it. It's huge. It takes precursors of glucose metabolism, acetyl-CoA and malonyl-CoA, and makes palmitate. It can make other things too. And it's intimately related to modifications and downstream elongation of fatty acids to really change phenotype. So when you get too much sugars, you make too much fats, and that has substantial effects on physiology. So with the help of many people, some of whom are in the room, and all of whom have accomplished much more than I have, people like Mohammed Zayed, who's a surgeon who has his own division now, Carlos Bernal, who is more important than me, certainly. Is that right, Carlos? That's, yes. And there are many others, people like Irfan, people at other institutions, Babak Razani at Pittsburgh, Katsu Fanai at Utah, outstanding folks who've made major contributions, and I won't go into these in detail, but for the last 20 years or so, we've characterized that if you make FAS go up or down in many different tissues, you can mimic essentially all of the phenotypes of diabetes, which is kind of fascinating. I won't go into. We have a very recent one in collaboration with a group in Germany that the level of fatty acid synthase in the liver determines how well you use dietary polyunsaturated fats. So if you make a whole lot of endogenous fats and you take fish oils, they don't work, which is kind of fascinating. And again, that's a collaboration with a group in Germany. So I have 3 parts of this talk. The first part I wanted to remind you, hope you've given you the idea that since diabetes is much more than glucose metabolism, we still don't understand what causes type 2 diabetes. It is truly uncertain. And since uncertain mechanisms cause diabetes and obesity, patients are not to blame for their diabetes and obesity. We don't even know what causes the obesity epidemic, and I'll give you the data in support of why we should not blame folks for this. So it is absolutely true that obesity is a robust risk factor for type 2 diabetes. When you have increased adiposity, you promote insulin resistance and beta cell dysfunction. How increased adiposity increases insulin sensitivity and promotes beta cell failure is unknown. But it's also true that if you lose weight, you improve insulin resistance and improve beta cell function. And most importantly, the cause of the global obesity epidemic is unknown. So I want to make it clear that obesity and diabetes are diseases that are discriminated against because people think it's the patient's fault. And the most common thing we do is said, well, you look at somebody who's big and you say, well, you need to have diet and exercise. And that's really a canard. It's absolutely not true. So these are some of the potential mechanisms underlying the obesity epidemic, which a lot of smart people in the world are pursuing avidly. So there is evidence that viruses may be involved. Many case reports of people who get specific viruses, and there's disruption of satiety centers in the hypothalamus that lead to unregulated appetite. Climate change and environmental pollutants, widespread cultural change. People are smoking less, that's certainly true. They may be exercising less, that's not as good. Psychosocial effects. There's a fair amount of literature among the psychologists that social media has contributed to the obesity epidemic, and they have good data in support of that. There's a fascinating hypothesis I won't talk about called the protein leverage hypothesis, is that maybe the ultimate component that's sensed is protein. But the two I want to focus on, which are most popular among obesity scientists, is the energy balance model and the carbohydrate insulin model. So did you guys realize that when we write a temperature of 37, it's probably wrong? I've noticed that in my patients. Almost none of my patients have a normal temperature of 37. It's lower, and it's just one of the canards of medicine. And there's evidence to support this from several different groups. This is one of the largest one, a group of ID docs at Stanford University, published in eLife a few years ago. And these are among different racial groups, these are body temperatures over the last 150 years or so. And they're clearly going down. So, and yet we still say that a normal temperature is 37.0. It may be a degree lower than that. And there's lots of evidence, at least lots of mechanisms that may be responsible for this. There appears to be decreased population levels of inflammation. People are less inflamed, even though we're obsessed about CRP and other things like that for vascular disease. There's less general inflammation. One of the big things is that not everybody who's walking around has active tuberculosis. That was probably true 100 years ago. There was an awful lot of TB, especially in St. Louis. And people have better dental care. So periodontitis causes active increased metabolism and increased heat. And again, the build environment is different. There's changes in ambient temperature. So the ambient temperature is cooler, and so this may contribute as well. And remember, this is relevant. We are less hot because we have less metabolic rate, the bigger determination of that. And that's a complex interaction with the bugs that live with us, the chronic diseases that we have, and the foods that we eat. So along with that, there's an elegant paper that's been published recently that did very rigorous determination of metabolic rate. So what this group used was the doubly labeled water database on adults. Doubly labeled water is a way of actually determine the production of CO2, which is the consequence of normal metabolism. So that's associated with the generation of heat. And you do this by using deuterium and C18 and correct for urinary water losses. And there's compelling evidence that over the last maybe several decades, maybe 100 years, there's been a decline in basal energy expenditure. This has been replicated in a larger database of basal metabolic rate. And the mechanism for this is uncertain. If you look at this in groups, this is total energy expenditure. You can see it's going down a little bit. Basal energy expenditure was significantly decreased. And this is activity-related energy levels, which are maybe going up a little bit. So if you think about this, patients always tell you they do everything they're doing right, and yet they don't lose weight. There's a molecular explanation for that, and I have two pieces of evidence for that. First of all, true basal metabolic rate appears to be declining. Nobody understands why. This is of substantial public health relevance, and nobody understands the mechanism for this. And that's reflected in body temperatures being lower, too. It may be as trivial as we don't have TB anymore, but I doubt it. There's probably something else going on. These particular authors cited the possibility of changes in fat intake and dietary fiber. What's happened for sure with the food industry and agribusiness is we've just stopped eating dietary fiber. Dietary fiber, when you eat it in large amounts, it actually improves glucose tolerance. It actually increases metabolic rate through complex effects. There are good clinical trials for that. And again, they also suggested that there's decreased immune activity due to decreased pathogens, so which is certainly a possibility. We're not as sick as we used to be, but that may have contributed to the fact that we're getting more obese. So this is, that was data in support of the notion of the energy balance equation. People are eating more than they burn, and they're burning less, so they have an increased risk for obesity. So this is the carbohydrate insulin hypothesis, and there is a large amount of data, some actually have been contributed by Tom Baranski, that sugars are bad for metabolism, especially simple sugars in excess. And that's certainly what the diet in the United States has been now for decades because of big agribusiness. This was one of the most elegant studies I've ever seen of this. It's an epidemiologic study, and it took advantage of a natural experiment. This was published in Science just 3 weeks ago. So sugar rationing was common in the UK during the terrible times of the war. The UK was bombed, and there was no food. There were no boats coming in because they were being sunk by submarines. And so sugar was just unavailable to most people, so it was rationed. The average amount of sugar eaten by an adult during the rationing period was about 41 grams. So this suddenly ended in September of 1953 when the government announced in the UK that you can eat all the sugar you want. And so that's what people did. There's sugar, let's have it. So this is an epidemiologic study, and I apologize about the resolution of this. So they compared 38,000 people who had been rationed versus never rationed. And so this is the discrete time when the end of rationing took place. And so this is people who were rationed for up to all of pregnancy, and then for 20 months after. This is an Inaugural effect. And these are people who, around the same time, were not rationed. And this is hypertension, and this is diabetes. And what this data is the development of type 2 diabetes and hypertension 30 and 40 years later, which is absolutely amazing. You should read this paper, it's fantastic. In the supplemental data, I guess they didn't think it was important, these people also had a decreased incidence of obesity. They were less obese and had less risk for obesity. So obesity is driving this. But sugar exposure in high levels around the time of birth and in the utero promotes chronic metabolic disease and promotes many other diseases as well. So again, apologize for the resolution of some of these slides, because I think our tech overlords are viewing stuff and then searching and then screwing up the format. So please, Mark Zuckerberg, please don't hurt me. So anyway, so these are the two major hypotheses as to why people have become obese over the last, and this is a worldwide problem, over the last several decades. The energy balance model and the carbohydrate insulin model. So they differ. One is that positive energy balance results in net fat disposition. And again, I showed you data in support of that. And then altered fuel partitioning because of simple sugars. Simple sugars actually tend not to be metabolized. They're easily stored. So if you have a diet very high in simple sugars, because of fatty acid synthase, they go straight to adipose tissue, and you promote the development of adipose tissue. So that's certainly a feasible thing as well. The point of entry into the system is the brain for this one, because you get positive energy balance, then you get gliosis in certain parts of the hypothalamus, so you can't sense food correctly. And in the periphery for this one, because you're depositing a whole lot of energy into peripheral fat. So both are caused basically by the same thing, a striking difference in the way we eat over the last several years. So this is one of the coolest papers I've read in the New Yorker in the last couple of years. So it was published in this dual issue about 18 months ago. And it's really disturbing. So it shows you a picture of a taco that has been designed and is basically a technological delivery device. And that's probably true, because they interviewed multiple people who work for Taco Bell, whose goal is to basically, I'm using the wrong psychological term, basically to addict us to foods. So we have to eat unhealthy food and have to go back and eat more and more. And they're very good at it. Taco Bell has an experimental kitchen in north of Dallas where they do surveys and work with food chemists to actually make devices. And many of these are specific fats combined with simple sugars that make you want to crave another thing. For those of you who are of a certain age, Lay's had which is a Frito-Lay company a few years ago, and bet you can't eat just one. Turns out that was their business strategy. So you thought it was a marketing ploy because it was so good. They're very good at addicting people, and apparently they're better than Burger King's Bacon Sundae, Pizza Hut's hot dog stuffed crust, Cinnabon's pizza bun, and KFC's, I don't know what the hell this is, fried chicken flavored nail polish. It was Antonia did a great job of writing this, but it's quite disturbing too, because the profit motive here is to make foods that are intentionally bad for people, and they've been very successful at it. So this is the data that they've been successful. So this is a couple of weeks ago in Lancet. They combined overweight and obesity. Hopefully you guys know what that is. Overweight is a BMI between 25 and 30. Obese is a BMI above 30. So about 75% of people in the United States are now overweight or obese, okay? That's a striking number. So the worst numbers occurred for females between the ages of 15 to 24, which is represented here. You can pick out Missouri if you want there, if you wish. There was a kind of an optimistic paper that was written 6 days ago. It showed up in one of the JAMA online journals that claimed, they had BMI data for the last 10 years for obesity only in adults, and they only look at obesity, they didn't look overweight. And they said that for the first time they had a modest decrease in 2023. But it's not exactly a positive paper, because they said this modest decrease because the people with the highest BMI have all died off. So again, we should be optimistic that we have this under control, or that we're doing the right thing for populations. So I said that obesity was a risk factor for diabetes. In the CDC in November, it was published that now 15.8% of US adults have diabetes. It's 41 million people. It increases with age, it increases with weight. Disturbingly, it decreases with education. So we're creating an underclass of people who aren't well educated, who are obese and have diabetes and have suffering, and we need to do something about that. And as many of you know, there are about 100 million adults in the United States with pre-diabetes. So to make the data even worse, in November, Lancet published one of their issues that now there are 828 million adults in the world with diabetes. That's an increase of 630 million since 1990, almost undoubtedly because of a combination of decreased metabolic rate and a shift towards simple sugars and addictive foods. The largest increases are in low and middle income countries, and what is just a crime is that 445 million people in the world with diabetes are completely untreated because they don't have access to injectables or appropriate medications. These are expensive medicines. So when you have diabetes, this is information you know. Your life expectancy is much worse. This is true for all-cause mortality, for cardiovascular mortality, for cancer mortality. People with cancer who have diabetes are much more likely to die. and other causes of mortality. And the earlier you get it, the more likely you are to die soon. So a 50-year-old with diabetes who dies 14 years younger if they were diagnosed at age 30, 10 years early if they were diagnosed at age 40. And the reason why this is so disturbing is that when I trained, if we saw an obese person with diabetes in the pediatric clinic, everybody would run over there because we wanted to get their genes and look for MODY genes. Now there are more obese kids with diabetes than thin kids with diabetes that have type 1. So this is an explosion, and we're going to have a wave of people who are suffering because of metabolic and cardiac disease. So this gets back to part of the point of this lecture. This is a very elegant paper published in January 2024 about the stigma of diabetes. All of these statements apply to a greater extent for people with obesity. About 80% of people with diabetes experience stigma. 20% of people with diabetes experience regular discrimination. One of the most disturbing things I've seen is that people get hassled when they go through an airport check-in because they're carrying needles, and I have to provide letters to them, so I don't know who they pick out. It's just a very disturbing and disquieting thing. And this is something we all are a little bit guilty of, although it's hard for us to admit this. So the societal view is that people with diabetes are to blame for their condition and its complications. There's a lot of social psychology data about this, is that people assume that people with diabetes are weak, lazy, or lacking in motivation, willpower, and self-control. And we don't even understand the effects of the existing clinical interventions on diabetes and on diabetes stigma. It is a little stigmatizing when you see somebody who is overweight and wants to do something about it, and you say, well, you should use diet and exercise. In a way, you're kind of blowing them off. So we're not certain of the implications of that, and it may be a little bit defeating and stigmatizing by simply saying that without more information. So I hope you understand now that there are uncertain mechanisms, and people aren't responsible for their condition. There are societal forces at work that are having major effects on metabolic disease. So how about lifestyle modifications and GLP-1 receptor agonists? We'll talk a little bit about that. So as it turns out, this is the story of a successful scientist at Washington University. Okay? All of us come out, we finish training, we do postdocs, we work hard, we start doing great things. But then we start writing grants, and we start gaining weight, and we just eat badly, and our insulin resistance goes up. And around here somewhere, we start hypersecreting insulin. Curiously, nobody knows why that takes place. It is not because of glucose levels. So there is something else that causes hypersecretion of insulin, and it is in response to the insulin resistance to make sure that you maintain a normal glucose level as long as possible. Then you actually get promoted, you get tenure, you have more insulin resistance, you start going out to parties, you invite people from other places, you start drinking too much. And somewhere along the way here, you have failure of insulin secretion. Nobody knows what causes this either. It's not clear that the beta cells go away, although they might de-differentiate. That's a fascinating amount of data that's come in part from Maria Remedy at this university. And then you get type 2 diabetes. The problem is this is a continuum, and you develop diseases even when you have prediabetes. You develop conditions that are a problem. And the most amazing thing, and one of the beautiful things about science and medicine and life, is that all of this is controlled by beta cells. And all of your beta cells, if you're healthy, weigh about the weight of a dime. So a dime weighs about 2.2 grams. That's the weight of beta cells in the body, and they determine ultimately your risk for chronic disease, obesity, and the way you're viewed by society. Incredible story. So let's say you tell somebody to lose weight. Okay, and say they're incredibly disciplined. They do the right stuff. They have diet and exercise. They are doomed to regain the weight. I'll show you some data in support of that, but this just simply happens. And the mechanisms for this is because there are sensors. There are sensors in at least 3 places now because of a paper that just appeared in Nature last week. The most important sensor is in the brain. Your brain knows what your highest body weight was. And then if you lose weight, it spends the rest of your life trying to re-achieve that highest body weight. Lots of data about this. It's called defending maximum body weight. If you think about this, these are evolutionary pressures that have developed over millennia. So during periods of time when there was absolute no food, you developed mechanisms to try to regain food and conserve metabolism as much as possible. So, and much of this is radiated by neurons that are depicted schematically here. AGRP neurons that increase food intake, and POMC neurons and leptin signaling that defends body weight. And the other thing that I still talk to medical residents and students, and they're just shocked because they don't believe this. So when you stop eating and you lose weight, you lower your metabolism drastically. This has been known forever too. And the mechanism is a sensor in the liver that turns on a deiodinase that takes iodine off the wrong part of the T4 molecule. Got it? So there's real T4, thyroid hormone, one of the largest prescribed drugs in the world. So normally, T4 gets converted to T3, which is the removal of this iodine by a deiodinase. And this makes you metabolically active. Thyroid hormones are responsible for a lot of basal metabolic rate and many other critical functions. So when you lose weight and you stop eating, you induce a different iodinase and you remove this one, an inner ring iodine, and you make reverse T3. And this is inactive. It does not bind to its nuclear receptor. And metabolic rates drops. So I mentioned there's two sensors, one in the brain, one in the liver. There's a really beautiful paper in the current issue of Nature that says there's actually a sensor in adipose tissue. This was done by lots of sequencing and adipose tissue biopsies of humans who are obese and lost weight, and in mice. And they characterized this as being adipose tissue retains an epigenetic memory of obesity after weight loss. And they at least had animal studies that showed that if they had this particular signature, these animals rapidly regained weight when they had access to normal food, not high-fat food, which was kind of amazing. So look at it if you would. Again, there are things against us to keep weight off because of these sensors. So has the US government ever done an elegant study of weight loss and diet and exercise? They have. It was called Look Ahead. It was published about a decade ago. And it was a beautiful study because it wasn't run by docs, it was run by nurses. They called people every single day. They went to their houses. They made sure that they ate the right thing and that they exercised continually. It was incredibly hands-on and it was a successful study. So there were 5,000 people with type 2 diabetes followed for up to 13 years, 14% had heart disease. There's their BMI, which is 36. This is their weight. Look what happens in the first year when there's active intervention, they do it. But look what happens to their weight over time in the intervention. They regain weight. Physical fitness goes up when the nurse stops hassling you about exercising, it goes down. Waist circumference drops, but then increases. Glycated hemoglobin, the same thing. It was considered a failed study because there was no impact on cardiovascular event rates. So these are the curves. So it really didn't do much for that. But amazingly, most of these people have continued to be followed by the NIH. And there's a recent paper that shows, that looks at the follow-up of these people that was published this year in Diabetologica. So, and they looked at the first year, there was an amazing event that took place. About 11% of people in the intense group actually achieved diabetes remission. Their diabetes went completely away. And then they followed those people over a period of time when they came back at the interview for a follow-up and they were still in remission. And if you had multiple visits where you were still in remission, you were very unlikely to get CKD. You were very unlikely to get cardiovascular event rates. So remission is possible in a subset of individuals. So that's a hopeful thing to do if you actually are aggressive and continue to follow things. So are there drugs that you can use to increase the chances of remission and to lose weight? Well, the story actually begins at Washington University in 1967. And it was a study published by David Kipnis, who was a former chairman of medicine here. So what Kipnis and Perley did, they measured plasma insulin in response to an oral glucose load. So this is, they did a glucose tolerance test orally and by infusion. And this is an obese group, and there's a normal weight group. And you can see the glucose levels are not different between these two groups. These obese patients did not have diabetes. But look at the insulin levels. Again, you inject glucose, and you get insulin levels that go up a little bit. But if you take glucose orally, you get a striking increase. So Kipnis was pretty smart. So he said that there was a mechanism triggered by oral ingestion of glucose that was independent of peripheral glucose levels. And it had to be mediated by the upper GI tract because he actually also studied people with portal cable shunts. He studied a number of people that actually shunted the portal vein back to the vena cava. And those individuals had a preserved effect. So he said there has to be a protein that's involved, probably in the gut, and he contributed this to the incretin hypothesis. Well, lots of years after that, the incretin hypothesis was mediated in part by GLP-1, which is a processing of a larger proglucagon form. And glucagon is studied elegantly by famous scientists at WashU like David Piston. So GLP-1 is a processing form that actually produced in the intestine. Years after that, a group discovered that type 2 diabetes is a form of GLP-1 deficiency. So if you look at the intravenous glucose here and the oral glucose in normal patients versus type 2 patients, you can see there's less of a burst of insulin in individuals, of GLP-1, I'm sorry, in individuals who have type 2 diabetes. So this is also a deficiency syndrome. And this was recognized with the Lasker Medical Award for Research. They gave it for obesity, but these two folks actually discovered GLP-1 as a mediator of the incretin effect, of being able to secrete insulin. And this elegant scientist at Novo Nordisk actually figured out how to make GLP-1 stay in the body for a long period of time, because she added fatty acids and other things on, so you could only have to give this drug intermittently. So what does GLP-1 and GLP-1 receptor agonists do? They do a lot of things. People who take them, and again, forgive the GME office for using brand names, but we're talking about Ozempic and Mounjaro. But these drugs have been around for 12 years. The first one was Byetta, still used by a couple of my patients. And what these drugs generally do is that they lower blood pressure. They have substantial GI effects that includes decreased gastric emptying and changes on lipoprotein metabolism. And they cause increased secretion of insulin and decreased secretion of glucagon. They also get into the brain. Some people think they don't get into the brain much. They probably get into the brain a lot in the hypothalamus, and they modify behavior. People feel differently when they take these drugs. So to summarize, at least 8 large cardiovascular outcome trials. There are at least 8. 5 of them were positive. Not every one GLP-1 receptor agonist decreases MACE, but most of them do. And certainly that's probably true for Mounjaro, not published yet. Certainly true for liraglutide and semaglutide, which are Victoza and Ozempic. And so they decrease these multiple events. There's the GLP-1 agonist, and there's the standard of care for most of the GLP-1 receptor agonists. So this is just a short list of what these things are done, because you've probably heard about these drugs, right? Ozempic, Mounjaro, yeah. They've sold so much Ozempic that the quality of life in the Netherlands has gone up. You know, people are living better because they're made so much money from this. There's so much money. So all of these GLP-1 receptor agonists, there are different ones. There's a PO one for semaglutide. They actually all decrease body weight and lower glucose. These 3, liraglutide, dulaglutide, and semaglutide, that's Trulicity, decrease cardiovascular risk. My patient was on Trulicity. It's because of what her insurance would allow her to have. That's a whole other issue. So semaglutide and tirzepatide in obese people with HFpEF decrease symptoms and death. This almost seems like a ridiculous paper, because you give semaglutide or Ozempic to people with knee arthritis, they decrease weight and they have less knee pain. But it's much more than that. I've had patients who've taken this who have knee arthritis, and their knees feel better. So the hypothesis behind this is that some people think the GLP-1 receptor system modifies toll-like receptor signaling. So it's a complicated issue. Retatrutide, which is the new one that's going to come and will be marketed before long, which is a triple agonist of GLP-1, GIP, and the glucagon receptor, reduces liver fat to a striking disease in MASH. And there was a paper at the ASH meetings just this month that showed that if you take these things, you're less likely to get DVTs and PEs, and there are many other things. So one of the more interesting ones, as I mentioned, when you start taking these drugs, my patients all report that they feel better. And the way they describe it is that they have a different attitude about food. They feel better about food, and they generally tend to be less anxious. There are many other studies that are in process, and many of the major drug companies have already decided that for substance usage disorders, they're going to do large studies about this. But a really interesting paper that appeared just recently in JAMA is that it appears to work for alcohol use disorder. This was a cohort study that lasted for many years. Lots of people with alcohol use disorder. They compared GLP-1 receptor agonists versus non-use of the agonists. These are the numbers they had. And there was a decreased risk of hospitalization with 2 of the drugs. And the 2 drugs were liraglutide and semaglutide. So it could be used for a number of central nervous system diseases. Then I mentioned that in Look Ahead, there was a subset of people who went into diabetes remission. Their diabetes just went away. And it maintained for 13 years, which is kind of amazing. So Lilly did a study where they gave tirzepatide, which is Mounjaro, for obesity prevention and diabetes prevention. And it looks like the way this was advertised is this is the miracle drug that will prevent everybody from having diabetes. But this is a very carefully selective group of people, if you look at it. They had 1,000 people. Their BMI was 39. Their A1C was 5.76, which is just barely prediabetes. So 5.6, you wouldn't have prediabetes. And their fasting glucose was 101. You have to be above 100 to get prediabetes. So just barely had prediabetes. And one useful part about this study is they actually stopped the drug for 17 weeks to see what happens when you stop it, because that's an unresolved issue with these drugs. Do you have to take them forever? So you can see they pooled the groups from 3 different doses of tirzepatide. And this is the placebo group who actually develops type 2 diabetes over the follow-up, substantial. and this is the pooled group of the other ones. So what you can see at the end, that people do have an increase in body weight, but this is a 17-week follow-up study with no drug, and so you don't immediately regain the weight afterwards, which is kind of an encouraging piece of information. This came out terribly because of resolution, but based on this, just less than a month ago, a group at Children's Hospital in one of the cardiology journals made the argument that 136.8 million adults in the United States meet the qualifications for taking GLP-1 receptor agonists. So to remind me, there are 258 million US adults, so more than half the population meets current requirements for taking GLP-1s. So it is likely that these drugs are going to dominate culture for a long period of time, unless something god-awful happens. Remember, these drugs have been around for about 12 years. I think it was 2013 or so. Max Peterson would know the date better than me. These drugs have been around for a while. So the last thing I want to talk about is the new age of enlightenment for metabolic diseases that's coming, but its widespread benefits are going to be very uncertain. So let me remind you about the original age of enlightenment. It took place in the setting of the Black Death, which was caused by Yersinia pestis. So the plague lasted, I always think historically when I was taught the plague, I said, well, maybe this was bad for a couple of years and then, it went away. But it lasted for 3 centuries. People were still dying of bubonic plague in 1720. It accounted for about death of the 30% of the population of Europe. And it was an amazing stimulus for it's probably correct. Superstitious behaviors, not stupid behaviors, although they were stupid behaviors too. The most common superstitious behaviors because of the times was that if you were accused of spreading Black Plague because you came to the town, you had to be a witch. So you were killed. So, and that was done, people were ostracized. Talk about a stigma. That's a stigma. So, but it was associated with what social scientists and historians have said. During times of great societal stress, there's an explosion of innovation and creativity, and it brings out the best in scientists. And I expect great things from all of you because of the COVID epidemic. So there was the immersion of observation, sophisticated math, and technology like optics. And look at the parallels to SARS-CoV-2. It's still going on. People are still dying from COVID. The CDC just published the most common death rates in the United States for the past year, and COVID was down to number 10. It was much higher sooner. It's probably responsible for about 20 million deaths. The official number is lower than that, but the Economist tracks this, and this is what they think it is. More superstitious behaviors. Perhaps you guys have heard of hydroxychloroquine. You've heard of bleach. I didn't put that on the slide because I thought that would be too adversarial. Ivermectin. Who thought of this? And again, people have websites about this. It's just staggering. And reassuringly, it's been associated with the emergence of biologics, antibodies, cell-based therapies, and generative AI, because you can't give a talk without mentioning AI. So if you do science or practice medicine, you owe a tremendous amount of gratitude to this person named Francis Bacon. So Bacon is credited with developing the scientific method. And he made some predictions that have turned out to become true. So he predicted that science would eventually prolong life and cure diseases. This is true. But he also pointed out that uncertainty would always be unavoidable. Remember, that's the title of this talk. Certainty is a futile thing. It's just, you're just not going to get there. Something mentioned by Blaise Pascal. It's unavoidable because science is conducted by humans, and humans always have flawed reasoning. So we talk a lot about biases now, but Bacon talked about biases and wrote many papers about this a couple of hundred years ago, or maybe it was 400 years ago. He called the biases the idols, and he called them the idols of the mind, the biases that keep us from seeing things for certain and being dominated by uncertainty. And he had 4 of them. One was the bias of the tribe, which is translated as the peer group. This is probably an homage to Plato, for those of you who've done classic literature. So the cave, individual biases. The marketplace, which is politics and business. And then the bias of the theater, which is dogma. How hard is it to change dogma? The dogma that we live now is that if you have obesity or diabetes, it's your fault. It's not. There are forces at work that we don't understand yet. And so that's an example of the dogma. He also said an amazing thing. He said, it was incredibly important to tell a story to convey truth. How many times have you talked to a mentor who said, well, what's the story you're going to tell here? Well, the narrative is the way you convince people to overcome their biases. So now I want to get into the notion of truth, which is going to disturb a lot of people here. There are 2 types of truth. What we deal with is mostly contextual truth when we talk about science. but there's also rational truth. And this has been talked about among philosophers for a couple of millennia again. So examples of rational truth is the fact that it's absolute. It is true prior to your experience. It's true by definition. An example of rational truth is mathematics, which is an amazing thing. The statement, no bachelorette is married, is rational truth. And then, I am a good person. That's an example of rational truth. Think about that. Okay. What we mostly deal with, although we have to deal with rational truth because it dominates our biases, is factual truth. Factual truth is always contextual. And it's contingent on conditions and true as it happens. I'm going to give you 2 examples of this that will, hopefully get you thinking, at least ask to see waterfall plots when you look at clinical trials. And probably this was best stated by a pre-Socratic philosopher named Heraclitus, who was an interesting guy if you read about him, 500 BC. Apparently he's mooched off other people like Socrates does, but he wasn't good looking and he didn't smell good. This is what's written. So he would show up at people's houses. He says, I'm brilliant, will you feed me? Now apparently Socrates, could get away with that, but Heraclitus not. So, or maybe Socrates just, cleaned up his approach, his spiel. Heraclitus is famous for saying, no person ever steps in the same river twice, for it's not the same river, and they're not the same person. This is the reason why the dogma that we have based on clinical trials from 30 years ago may not apply to today, because things always change. And that's why we have such a wonderful job, because we're trying to translate truth for the patients that we want to decrease suffering. So here are a couple of examples of contextual truth relevant to GLP-1s. Now, it's in the interests of major pharmaceutical companies not to show you these kind of data. This is the only one that I've seen from a GLP-1. It's always in the supplemental data. This was like supplemental figure 4 of one of the Ozempic trials. Haven't seen any for Mounjaro. They just don't publish them because their story, their narrative is that these drugs make you lose weight and cure diabetes. They can't say that, but that's their story, right? But it turns out not everybody who takes Ozempic, semaglutide, loses weight. In fact, about 15% of them consistently gain weight. They all wind up in my clinic. They said, why have I not lost weight? And then they scream at me, and then I try to figure out ways to give them small gifts so they can go home. So this is an example of the control group. You can see that half people gain weight, half people lose weight. What you're doing with many intervention is you're shifting the curve. These are called waterfall plots. I've talked to these medical students, and they say, what the hell is that? It's because the insurance companies, and the pharmaceutical companies don't want you to see that because it adds uncertainty and contextual truth. So for this person, this drug works great. For this person, this drug doesn't work at all. The truth is contextual. It's even been around longer than that. There are many examples of this. I can go into one about aspirin that we're still using for primary prevention and probably should not for most people based on contextual truth. But here's an elegant paper written by Paul Ridker. And it was based on the Jupiter trial, which is a reported very large pile of rosuvastatin that's used for primary prevention of coronary heart disease. And so the rational truth that everybody thinks is that when you take a statin, LDL is lowered. It's not always true. Ann Goldberg has seen, she's one of the world's experts about lipid metabolism. Some people take these drugs and the levels go up. What Ridker found from this waterfall plots from the Jupiter trial, about 15% of people had substantial increases in LDL. And yet, curiously, they still had a benefit from taking the statin. So the rational truth is that these drugs always lower LDL. They don't. But the story is much more complicated than that based on context. So this brings us to the notion of rational truth in populations and what our society wants us to do. Has anybody ever heard of the panopticon? So Jeremy Bentham was a jurist and a philosopher that lived in these days. He was a utilitarian, which has some problems. He thinks that right and wrong were defined by what makes the greatest number happy. So with doing that, at the time in Great Britain, there was a lot of problems with crime. There were a lot of poor people who were committing crime. So the big business was to try to figure out how to imprison people and keep them under control. So basically. So he came up with the idea of the panopticon, which basically you put everybody in the prison in cells that were around the periphery, and the guard tower would have a little slit where you could see the people. And the people would behave because they think they're being watched. And it turns out in social psychology, it works. It's relatively inhuman, but it works. This is the panopticon. So you guys think this is not relevant to you. This is actually the best picture I could get for free online. This is an abandoned Cuban prison where it was widely used for much of the population to keep them under control. And again, control them because they were watched through this little slit. You don't know you're being watched. This is the Stateville prison in Joliet, Illinois. For those of you who have seen the Blues Brothers, Joliet Jake stayed in Stateville prison. And this was called the Roundhouse. This is actually a view from the prison guard side, the little slit that you could see out. And it was a way of controlling people. Well, it turns out this metaphor has been used by a famous philosopher that applies to everything that we do in medicine today. So the philosopher was Michel Foucault, and he wrote a book about the academic medical center called The Birth of the Clinic, and it was published in 1963. And disturbingly, a lot of what he wrote has come true. So what Foucault said, that the prisoner in the panopticon and the patient in the clinic are objects of surveillance. He talked about the fact that doctors used to be a sage you would go to who would help you with deal with issues, who would spend time with you and observe you. But he predicted that what would happen, that medicine would change from classification to observation and then back to classification, and this has kind of happened. He said that science would be elevated as the ultimate arbiter of truth, but an arbiter that was biased by culture and society. He also predicted that since science was so important, eventually we would worship biopower, and we would avoid death. And how many tech moguls do you know who are trying to download their consciousness to some server somewhere so they live forever? So Foucault was actually, he called this the medical gaze. And so this was reevaluated by a scholar named Teagarden a couple of years ago. And perhaps in a homage to The Big Lebowski, Teagarden concluded that the gaze abides, it endures. And it objectifies people through radiologic imaging, through sequencing, through omics, and through algorithms, and a return to classification. It basically has the danger of potentially dehumanizing people, which will decrease our ability to provide care and decrease suffering. So let me tell you what I predict for the coming enlightenment. I'm almost done. I don't know if any of these clocks are right. They're probably wrong. So obesity and diabetes, heterogeneity will be codified. Remember I said it's not people's fault. We'll figure out what the cause is, and this is going to happen with the extensive, intensive evaluation that's being done now. These are just predictions. There's going to be ubiquitous continuous glucose monitoring, with monitoring expanded to other analytes, including ketones, fatty acids, other things that circulate, and people will modify their behaviors based on CGMs. If any of you have ever given somebody a CGM, they change their behavior, and they do it without any change of their medication to make their glucose better. So this will be more monitoring, and it will be stored in the cloud, and Mark Zuckerberg and Elon Musk will be able to look at it, which is the disturbing thing. Cell-based therapies will render some people with diabetes insulin-free. So this is being led by an incredibly powerful and gifted scientist, Jeff Millman here. So he's actually led the ability to take peripheral fibroblasts, turn them into beta cells, and cure diabetes in models, and some of this is taking place through a licensed technology in a company in Boston. So GLP-1 modulators and other approaches will permit substantial weight loss and will allow remission in some people with diabetes. There's also going to be technology that will allow normalized glucose with minimal patient input. Smart insulins are coming. You guys know about smart insulins? Smart insulins actually sense when glucose is available, and then they dissolve from their matrix and are released. So it's going to be possible to give insulins that act immediately, as opposed to the little bit delay now that actually interferes with us and causes hypoglycemia. But despite all this, uncertainty will be pervasive, because we're going to use these novel therapies in the setting of liver fibrosis, vascular disease, retinopathy, proteinuria, neuropathy, all terrible problems, and we don't know how any of these are going to be affected by these new interventions. So how will knowledge be disseminated and therapies implemented? So this is going to require incentives, and they're going to have to be financial incentives. So wise leaders at this medical center will have to make sure that money is spent in a way that it modifies people's behavior. So in the data for the year for the most data was available, 30% of healthcare dollars were spent in fee-for-service with no link to quality or value. So this went down from 41% for the previous year. But really what's happened is you need to have arrangements with downside risk. If you pay for medical care and the medical care doesn't actually improve the health of populations, the payment should be returned. So that's something that business people don't like. That's downside risk. And that's a minority of systems in the United States, 29%, which is up a little bit. So you need to put systems at risk. If you're doing something and you're saying you're providing health, let's provide health. So there are complex obstacles to healthy eating. You know, eating healthy costs more than eating bad food. This is just the truth. And people discount future risks. The social psychologists have known this for a long time. Something that's going to happen 30 years from now is not as much of a threat as something going to happen in the next week. So we've got to figure out ways to modify behavior. We've got to figure out optimal use of GLP-1 and related agonists. I have several patients, and again, this is anecdotal. I'm not recommending things that's off-label use. But some of my patients, they will lose weight and do all things right, continue diet and exercise, and then take it at a much less frequent interval. and seem to maintain weight for a long period of time. And again, anecdotal evidence, but we need to study that formally. And then you can bet that major agribusiness in the United States is trying to figure out how to make GLP-1 resistant foods. They are following people maybe at that facility in North Dallas, which gave us Bet You Can't Eat Just One. They're trying to figure out how to make stuff that's GLP-1 resistant so they can sell more of their foods because their bottom line has already been hurt. People are amazingly eating less because these drugs really work. Why not let's develop addictive healthy foods? Why not have an inducement to actually make foods that you have to eat that are healthy for you and actually contain fiber and decrease event rates? So we need to develop system-driven exercise and diet intervention in populations. And then we need to realize the growing value of direct human contact and dealing with uncertainty. It's really important when you see people, it's becoming increasingly rare, telemedicine may or may not be going away. We're uncertain. We don't have the final word from CMS. But just the act of interacting with someone, having them touch you, having them express to them that you care about them and that you want to have a good life is an incredibly important thing. So, and let me remind everybody that love and concern for patients are not scalable. You can't scale that in an app. You have to express that with an interaction with the person every time you see them. So this is what I've talked about. Patients are not to blame for their conditions because we don't really know what caused their conditions. There are lifestyle modifications, GLP-1 receptor agonists work better. There's a new age of enlightenment coming, but the benefits are uncertain. And I'll end with this, and I think Linda Repa-Eschen would appreciate this because she gave me books by Maya Angelou. Maya Angelou is a native St. Louisan. And if you think this is a heavy lift for us to do things about this, you should read about the story of her life. She didn't speak for 5 years because of an unspeakable thing that happened to her. But just read it. She's a native of St. Louis. So to be optimistic and do things, do the best you can until you know better. Then when you know better, do better. And the thing that I love to hear from her all the time is that people will forget what you said, people forget what you did, but people will never forget how you made them feel. Thanks very much for honoring Linda today. Stop it. Anybody got any questions? We're already over. So yes, Marina. The question is, should we replace T3? So over the age of 60, it kills people. If you go up to date, you can go to awful lot of people who feel much more energetic that are taking T3. It's a little like speed, but T3 says that you should not take it if you're over the age of 60 for obvious reasons. Increased risk of stroke, increased risk of AFib, bone loss, but I'll leave that up to you. That's a personal choice for you, Dr. Lipid. We're done. You guys can go.
Linda would be so proud.
I say good things about you because I'm proud of you.
No, I'm saying Linda would have.
Oh, I know. I think she would.
Proud.
I think she would.